And welcome back. We were just talking about megaloblastic anemia. We talked about other anemias, sickle cell disease, which is a normocytic anemia. We've talked about the thalassemias, which involves globin synthesis problems there. We've talked about microcytic anemia, problems with iron deficiency anemia. We've talked about how transferrin and TIBC is involved here. We have talked about impaired production, aplastic anemias, pure RBC aplasias, renal failure. And we mentioned that for defective DNA synthesis, causes megaloblastic anemia. Defective heme synthesis causes problem in iron production. And defective globin synthesis, as previously noted, is talking about the thalassemias. So we've talked about the red blood cell proliferation, erythroblast, normoblast, reticulocytes, and we've just started talking about the leukemias. So this is not a detailed video because you have seen a lot of videos and lectures on this. This is just a basic review to get your mind going for the test. The details are in your notes and in your book. So let's talk a little bit about the leukemias. Last time we said that leukemias are a malignant proliferation of white blood cells. We know this. And that in the case of the neutrophilic precursors, the primary process is marrow and peripheral blood, but it can also involve any organ or tissue which receives blood. But in the case of lymphocytes, there is an intimate concurrence with malignant lymphomas. We need to talk more about that. Leukemias. So for acute or chronic, myeloid or lymphocytic, childhood or adult, they all involve bone marrow. So how about acute myeloid leukemias, AML? What do you know about this? What does this involve? What type of cells? We said myeloid, right? So this is going to involve the immature progenitor cells, and acute, meaning that it comes on very quickly, and it's affecting the very early stages of the development of the cells. And remember that these leukemias accumulate in the bone marrow, and there is a preponderance of what type of cells? Of course, that's blasts that are making these cells. How about chronic myeloproliferative disorders? Chronic, so chronic should be the key here. And this is also myeloid. And here we have an increased production of one or more terminally differentiated myeloid elements, for example, granulocytes. And this usually leads to elevated peripheral blood counts. So this is now leaking into the bloodstream. So remember that all acute leukemia suppress normal hematopoiesis, and for example, you would end up with anemia and thrombocytopenia. And most have a predictable chromosomal aberration. And some respond very well, for especially the acute leukemias in children, and they respond dramatically to chemotherapy. So this should be remembered. So one more thing about the neoplastic proliferations of white blood cells, in this case acute leukemia. We should think about the process, the molecular pathogenesis of acute leukemia, and know that with acute leukemias, they are arising from complementary mutations that block differentiation at the early stages of white cell development, and the chronic would be later on. And these enhance self-renewal and increase growth and survival. An important example of each type of mutation would be, for example, a mutation in the tyrosine kinase mutation, enzyme, BCR, ABL. This will result in increased growth and survival in the tyrosine. So a mutation in tyrosine kinase would result that. And as for differentiation, this would be a mutation in transcription factor. And for increased self-renewal, this would be a mutation in transcription factor. So that would be MLL, or you could have transcription factor of PML, RA, or alpha. But then remember that there are there are factors, there are mutations that are involved in this problem that result in acute leukemia. So let's move on. We're going to talk about acute lymphoblastic leukemia. So we're not talking about myeloid anymore. We're talking about the lymphoid section. So we're talking about ALL. So what are we talking about here? This time we're talking about lymphoblasts, which can give rise to what type of cells? Either T or B cells. And these cells are the focus of the malignant proliferation. Remember, important point is that lymphocytic leukemias cannot be classified independently of lymphomas because they all have lymphoma counterparts. So if you're thinking about the lymphocytic leukemias, you also should be thinking about lymphomas. Now, where would you find LLL? It's mostly seen in what age? ALL, or acute acute lymphoblastic leukemia is mostly found in children. Most have chromosomal changes, hyperploidy, and remember the Philadelphia chromosome, translocations of 9 and 22. They have significant response to chemotherapy, and they can be a 90% remission and 75% cure. So when we think about the acute lymphoblastic leukemia, what would we see in the patient? We're going to see sudden onset, anemia, bleeding, fever, bone pain, adenopathy, hepatosplenomegaly, CNS. In the CNS, you'd see headaches, vomiting, nerve palsies. And these are all pretty much the similar symptoms to the acute myeloid lymphoma. Acute, what I mean to say is it's similar to acute myeloid leukemia. So these symptoms are similar here. So as I said, sometimes there's a mixing here, it gets confusing. But here we are talking about acute lymphoblastic leukemia, but it is this very similar symptoms to acute myeloblastic lymphoma. What am I talking about? Acute myeloid lymphoma. I'm getting really confused here. Anyway, let's move on.